Afternoon. It's my pleasure and privilege to introduce this special seminar and just remind us that it's through events such as the Cassel seminar, Tyroler lecture, and Harry Guest lecture that we have the opportunity to pause and honor some of the giants who not only influenced our department but also the field of epidemiology. And the reason that I will do this at those other seminars too, is that it's really important for those of you who represent the next gen of epidemiology that you fully appreciate those who became before you, those whose work laid the foundation for epidemiology as we know it today. And these leaders blazed trails that expanded the discipline in many directions. They were especially effective at bridging epidemiology thinking and practice of their time with other salient disciplines. They were so insightful through immersion in other disciplines. They were logical, creative, practical. They had a singular ability to create connections, to connect the dots in ways that others could not. And I say this for a number of the people that these lectures are named after did it in the era before high-speed computing, advanced epi methods, that they were really practitioners of generating creative ideas and making connections that others hadn't. Notably, all of the individuals, including John Cassell, were exceptional teachers and mentors. All were committed to inspiring the next generation of epidemiologists. And today we recognize this through this year's Cassell lecturer, Dr. Szklo, who's a true leader in our field of epidemiology. And I just want to say a few words about John Cassell. You may not know who John Cassell was. He was born in Johannesburg, South Africa in 1921. He received an MD from the University of Witwatersrand in South Africa. He joined the New Institute of Family and Community Health at the university, and one of his earlier and most influential for influencing the rest of his career was his early work on the health of a Zulu population. Really taught him the importance of cultural forces in the determination of disease, etiology, and healthcare delivery. In 1953, he left South Africa to obtain further training in public health here at UNC. His belief in the importance of the social environment as the determinant of the distribution of health in populations really, as I said, was greatly influenced by his experience in the practice of medicine in South Africa. And this view he had that was inspired by his work in populations in South Africa really proved to be innovative and at various times sort of controversial in the United States at that time. In 1958, he became the chairman of a fledgling Department of Epidemiology at the University of North Carolina School of Public Health. And one of the things that he's best known for, and one of his influences, was that he began to include health-relevant psychological, social, and cultural variables in the conceptual scheme for teaching and research in epidemiology. He hired behavioral and social scientists to join the faculty, along with physician, dentist, and nurse epidemiologists. The teaching program in epidemiology in the department at that time began to include such subjects as culture and health, family health, epidemiologic foundations for community diagnosis, social determinants of health behavior, and research into the delivery and evaluation of health services, as well as genetic, biological, etiologic studies. And through that work, he used North Carolina as a laboratory for a broad range of epidemiologic studies on what was going on in North Carolina at that time, which was a transition from a predominantly rural population to a more urban industrial population. He used that transition that's going on in North Carolina and drawing upon his knowledge and inspiration from different other fields and cultural factors to do his epidemiology. He was an early believer in holistic or integrative epidemiology, drawing upon many disciplines to address public health issues. At the time also, and through his career, he was resolute in his stands for social justice in South Africa and the United States. And I think it could really be said, and it's something that's a legacy of our department, is if you go to SCR, there's actually a Cassell lecture at SCR as well, that really he exemplified modern social epidemiology of his time and our time. So at this point, I've asked Steve Cole to introduce Moyses, and I just also want to, before I forget, there's the all-important, there'll be a reception just outside the room after the talk, and so Steve has known Moyses for a number of years from his time at Hopkins and now in his role in the editorial board of AGE. So, Steve?
Thanks, Andy. Hello, everybody. Moyses Szklo is professor of epidemiology, medicine, and oncology at Johns Hopkins University. He's humble, so he asked me just to say, "This is Moyses, my friend," and leave it there, but I thought I wouldn't. I'll tell you some other things he is at the end. He's the founding director of the Hopkins Graduate Summer Institute in Epidemiology and Biostatistics, the founding Hopkins PI of the ERIC study, which many of us know and love, the founding Hopkins PI of the MESA study. To date, he's mentored about 30 doctoral students, including Louise Brinton, Joe Koresh, and Alfred Morabia. He's published over 250 scholarly papers, including multiple impactful papers in the New England Journal, JAMA, and NCI. Several of his papers have been cited over 1,000 times. I get excited if I have a paper cited, but 1,000 times, it's kind of off the radar. At least 71 of his papers have been cited 71 times. And if that wasn't enough, while he was doing all of this, he was also the editor-in-chief at the American Journal of Epidemiology. And in these interesting economic times, it's a tough time to do science, not just epidemiology science. Two of the things that he led at Hopkins are notorious there for being the only two money generators for the Department of Epidemiology. That's the Summer Institute and the AJE. So with that, I give you your 2015 John C. Cassell Distinguished Lecturer, Moyses Szklo, who is smart, brave, tough, kind, humble, and funny.
Well, I wish my wife was here to hear all those compliments. Now, good afternoon, everybody. I just wanted to tell you that I attended one seminar given by John Cassell at Hopkins in 1975. It was awesome. He spoke without slides, without any notes, for an hour. And everybody was absolutely mesmerized by his talk, including myself. So it's an honor to be here, and I would like to thank my colleagues at the North Carolina School of Public Health Epi Department, Andy and Steve, for this very kind invitation. It's a real honor. And it's nice to be here and see people I like again. They usually only see at the SCR meetings. So we're going to talk about epidemiology for public health. Are we missing the boat? And I think the idea is, oops, what happened here? I'm trying to move this forward. Oh. So, okay. So it is very interesting that generation before mine, most of the so-called chronic disease epidemiologists and infectious disease epidemiologists, they had a public health background. People like even John Cassell, Warren Winkelstein, Morton Levin, Abe Lewinfeld, they all had worked in public health settings. And that flavor has been missing, I think, by and large. So I think we have to restore that. Now, one good example is Morton Levin. Morton Levin was a visiting professor at Hopkins, and he did some very important things. For example, he did the first well-done study of lung cancer and smoking. And he also developed the formula for the unadjusted attributable risk in the population. Today people talk about attributable fraction. Moore's term was attributable risk. And then he got an award from the American Public Health Association EPI section for his contribution to epidemiology. And this is what he said to me. When I got the Frost Award for my contribution to epidemiology, I was surprised, as I always saw myself as a public health officer. I believe my main contribution was to have facilitated the polio trials when I was a public health officer in New York. And actually, he is the one who demanded that the polio trials use a random schedule, a random allocation schedule. Now, one key component of epidemiology for public health is so-called translational epidemiology. I couldn't find any definition I found lots of definitions without clinical flavor, but not translation epidemiology. And this is a definition I came up with. I mean, it's just a try, an effective transfer of new knowledge from epi studies into the planning of prevention strategy, prevention policies and programs. So, I went to Michael Porter Dictionary of Epidemiology. I don't know, there's a new edition. I don't know if he's changed it. And this is the definition that he uses: the study of distribution and determinants of health-related states or events, and the application of this study to control health problems. So it has two components. And of course, this is the translation that we are talking about: how to change, how to apply knowledge into development of programs and policies and so on. And it's not easy. Translation is not easy. You're all familiar with this slide. I mean, it's been shown in 1,000 presentations. You know, there's something in between acquisition of knowledge and application of knowledge that is part scientific, part judgment, and so on. So in the process of translation epidemiology, of course, we start with evidence, of course. And ideally, we go to systematic reviews. And then we evaluate levels of evidence, programmatic options, which we call decision analysis. Sometimes we have to do that on the basis of single studies. Cost effectiveness is the next step, with or without sensitivity analysis. And then recommendations. And the recommendations are for what to do with policies. And they should be evidence-based. And there is a tension between evidence and some obstacles, including ethical problems, politics, and resources. So this is important. Now, so evaluation of levels of evidence is absolutely crucial for translation epidemiology and public health. And this is just a simple process. I'm simplifying everything because I was told by Andy that I have to leave some time for discussion. So and then Steve saw my slides, thank you, and he said, it's too many, 88 and so on. So I decided we wouldn't get out of here. So, this is a simplification, of course, and subject to criticism. You go from the highest level, which is experimental randomized clinical trials, all the way to expert opinion, not based on evidence. Now, I was talking to Steve a few hours ago, and it's quite clear that some observational studies are better than some clinical trials. So this is just a way to simplify the whole thing. And the assumption is that health problem is important in terms of disability, mortality, whatever, several criteria, cost of healthcare, and so on. And then you go to translation. And again, it's an inexact science, frankly. And it reminds me of William Farr's quote saying, "That is a fact, all else is inference." So you have the data. What you make of the data and how you apply is really subject to opinion, somewhat subjective. Then you have translation, and the United States Preventive Services Task Force in the Canada Periodic Health Examination come up with something like this. You have a certain grade of evidence, A, B, C, D, I, and then a certain level of certainty. For example, A is high certainty that the expected net benefit is substantial. And so on. And go to I. I, they say evidence is lacking or poor, so the expected net benefit is unknown, and so on. And then implementation. What do? I mean, with A and B, you implement. With moderate or high level of certainty that the evidence is small, you have to do it on a case-by-case basis. It's almost like prostate cancer. What do you say? You say to the patient, yeah, you have prostate cancer, let's take it out. And he will say, what complications there might be? And the patient is 75 years old. So you say sexual impotence, urinary incontinence, bleeding, surgical mortality, and so on. So this is a process. We need to create a process better than this. But this is more or less the idea of the flow of this process. Now, what I'm going to do now is talk a little bit about semantics, because I have noticed over the years that there is a discrepancy between what I would call, for want of a better term, academic epidemiology and the epidemiology for public health, translation epidemiology. So I'd like to discuss those four things that I think are important, those four issues that I think are important. And the first is this. Is confounding always a bias? Now we learn it is a bias, okay? In fact, this is a joke, so you can relax for half a second. And in fact, in some epi textbooks, people classify bias due to confounding, bias not due to confounding. Now, of course, confounding is a big problem in observational studies because causal inference is crucial for primary prevention. So if you have residual confounding, you have a problem. And there are bright people like Steve and Daniel who are doing all kinds of speculations and modeling and so on to overcome this problem of observational studies. Now, I just want to remind you that a lot of policies were based on observational studies. A lot of important policies, not on clinical trials, but observational studies, indoor smoking ban, radiation exposure standards, and so on and so forth. So observational studies have been good, and they're in good company. I mean, there are lots of observational disciplines, right? Geology, astrophysics. You can't randomize planets or stars. Maybe God can, but not us. Now, the key question, if there is confounding, is a confounded association useful for public health, or should we just say, ignore it, trash it? Well, actually, confounding and bias occur in different phases of what we call the natural history of a study. So you have this natural history, go from target population to sample, data collection, study findings. And selection bias occurs when you select your participants. Information bias when you collect data. Inferential bias when you interpret your study findings. But confounding, real confounding, is at the level of the population. So what people, sophisticated people, not me, would say is found in nature. What they want to say is out there in the population as a whole. And so let me give you an example of a useful confounding association. There's a relationship between African American ethnicity and hypertension. I have to drink water once in a while because my mouth gets dry. I apologize. So let's assume for a second that there is absolutely nothing in African American, no biological explanation why African Americans develop hypertension. That the explanation is due to confounding, is that it's due to confounding. So we know they eat a lot of salt, they gain weight a lot, they don't exercise as much, and so on and so forth. So the question is, so the conclusion is that African American ethnicity is associated with hypertension, but that's due to confounding. It's a confounded association. But is it useful? Of course it is. It's a high-risk marker, okay? It's useful for screening on this high-risk group to control for established hypertension, or focus on this high group to promote prevention or cessation of modifiable risk factors. So, is confounding a bias? Well, what is the answer that, any epidemiological question, it depends, right? It depends on what? Well, if the purpose is to infer a causal relationship, yes, is what I would call etiological confounding. But if it is to identify high-risk markers, public health confounding is not a bias. It depends on what you want to use it for. And again, statistics is a key instrument of epidemiology, but it should not dictate how we should apply knowledge. We should decide that, okay? All right, the second point that I want to make is this. 99% of the papers that I get in the American Journal of Epidemiology, they only talk about multiplicative models. Cox, logistic, Poisson, you name it. People forget about the additive model. And I want to provoke you and say, if you're interested in public health, forget about the multiplicative model. It may be good for model fitting. You can actually use Cox and evaluate additive phenomena, additive interaction, for example. So the issue is adjustment model versus application model. Example, when modeling ratio-based measures of association, heterogeneity is usually assessed using a multiplicative scale. So when people say to you, I found the interaction, you go to the model, it's Cox, they found multiplicative interaction. Now, of course, if the interaction is qualitative, it's going to be present in both scales, but except this specific situation, That's what is implied. I mean, when they say, yeah, I found an interaction, it's multiplicative. So the question is, should the model dictate the application, or should the application dictate the model? And I had several examples, and Steve didn't like. He liked the example, he said, too much. So I came up with one example that I think is a good example. So here's another joke. So half a second. Okay, relax. Okay, so this is a study, a real-life study. Let's imagine that the data are valid. Okay, we know that we cannot draw a causal inference on the basis of one observational study. But let's suppose that the data are valid and shows the relationship between smoking and asbestos exposure to lung cancer mortality. And what you see here is surprising. You see here, the relative risk for asbestos exposure is greater for people who don't smoke than for people who smoke. To me, this is completely counterintuitive, right? So this is a negative multiplicative interaction. It's like antagonism. Now, if you look at the absolute difference, there's a gigantic difference between those two absolute differences. So here we have strong positive additive interaction. Now, if you're planning for health policies or programs, which one would you pay attention to? Additive. Because the multiplicative has this strange property when the denominator of one of the strata is very high, it tends to dilute the relative risk. Okay, so that's my proposal. Okay, if you're interested in application, either medical application, public health application, go for additive, for the additive model. Yeah, I had other examples. For example, efficacy. Well, we have a formula, a simple formula for efficacy. But most people don't realize that the absolute difference is more important because the efficacy doesn't say anything about the magnitude of the problem. So the absolute difference has an additional advantage, and that is it allows you to calculate the number of people who need to be treated or subjected to a preventive action to prevent one case or one death. So additive model, okay? That's another difference between translational epidemiology and the usual academic epidemiology. And Ken Rotman will call this public health interaction. Additive interaction, he used the term public health interaction. Then the other thing is assessing homogeneity. You know from the Hills criteria, the old-fashioned Hills criteria. And, people say replication is the soul of science, right? This is something that the basic scientists pay a lot of attention to. And let's see what goes. Now, let's go back to the evaluation of levels of evidence. And this is a more detailed classification system of levels of evidence. And I don't want to discuss the merit of this classification. What I wanted to point out to you, of course, it goes from systematic reviews of randomized trials all the way down to expert opinion without explicit critical appraisal or based on logical deduction. So I don't want to discuss the merit. I just want to point out to you that no matter what the classification of those levels are, they all say homogeneity is important. So here you have for clinical trials, homogeneity. For cohort studies, homogeneity. And for case control study, homogeneity. That's the highest level for each type of evidence. Okay, it's a bunch of studies showing similar results. Now, we have a problem, right? And we have two issues here. One is what we call pseudo homogeneity, and the other one is what we call pseudo heterogeneity. Now, pseudo homogeneity is a cinch, very easy to understand because it has to do with publication bias. If you only submit papers that show, in quotes, positive results, obviously systematic reviews are going to be biased. Okay, and are the authors afraid? Now, you don't have to pay attention. You've seen this joke, okay, Steve? Are afraid of rejection of negative results. So, who is responsible? Is it the editors who don't like no results, or is it the authors who don't want to submit? And the answer is a little bit of each. So, Snoopy, this is Snoopy, right? Okay. I thought. First time I showed the slide, I said Mickey Mouse, but it doesn't look like a mouse. It looks more like a cat, but it's a dog. So he sends a paper, and Steve is the editor. And Steve writes, thank you for submitting your story to our magazine. To save time, we're enclosing 2 rejection slips. One for this story, one for the next story. But he doesn't give up. So he revises the paper and sends it back to Steve. Poor Steve, for his sins, right? So he gets a letter from Steve. Dear author, we are returning your worthless story. Please don't send us any more. Please, please, please. I love to hear an editor back. So there are some, publication bias is not a random phenomenon. There are some determinants of publication bias. One is there is an increased odds of publication findings are statistically significant. There is a decreased odds of publication for clinical trials results vis-a-vis observational results. Industry-sponsored studies are more likely to report findings that are significant than studies funded by NIH, for example, EPA. English written reports more likely to report findings that are statistically significant. And there's a way to evaluate publication bias. Not perfect, but you can do a bags. You can look at the graphs that plots standard error versus sample size, and then, versus relative risk or odds ratio, and then we have tests, statistical tests to look at. So the main problem is heterogeneity is more subtle, can be more subtle. So what I would call pseudo-heterogeneity means that the studies don't show similar results, and yet there might be a causal association between the exposure and the disease, or between an intervention and an outcome. And there are several causes of pseudo-heterogeneity. One, the most simple is difference in study design, procedures, analytical strategies. You know, if the studies have adjusted for the same confounding variables, yes or no. And this is simple, easy to understand. Now, more complicated is the differences in the phase of the natural study, the natural history, when the study is done. And, you know, a few years ago, many years ago, Arminian and Lilienfeld, they found out that the epidemic curve after the introduction of an exposure follows the same shape in chronic disease, in non-transmissible disease, and intransmissible disease, which is a log normal shape like this. So very interesting, they showed that for bladder tumors in distaff workers, and for leukemia and breast cancer after the atom bomb explosion, they fought, and this is what you see in point epidemics of infectious disease, exactly this. So what does it mean? It means that if you do studies here before the minimum incubation period goes by, you won't see an association. But if you do it here, you'll see an association. Right? Is there an example? Yes. The classical example is the postmenopausal hormonal therapy in breast cancer. The first few studies after the introduction of that therapy to the public at large didn't show an association. And actually, there's some interesting data from the Women's Health Initiative. The first 3 years after they started to take the hormone therapy, there was no association, no positive association, only after 3 years. So the implication is there may be the latency is 3 years. Okay? So this is another reason for heterogeneity between studies. It depends on the natural history. How long after the introduction of the exposure in that population, that study population. So that's third reason for heterogeneity, okay? So the first 3 years, there was no increase in the risk of breast cancer related to estrogen replacement therapy. Okay, that's another one. So different study populations may have different prevalences of effect modifiers. So just to go back to the same example, say if I do a study of never smokers, the difference, the attributable fraction, would be 31 per 100,000. But if I did a study in smokers, okay, the difference would be 555.2 per 100,000. Neither of them is wrong. Okay, they're both right, except that here everybody smokes, and here nobody smokes. And of course, you get in between absolute differences as the prevalence fluctuates, the prevalence of smoking fluctuates. So this is important, okay? Remember that you're using homogeneity, heterogeneity to either refute effectiveness or accept effectiveness when you have to decide on a certain policy or program or intervention. Okay, this is another one which is really funny. Variability of exposure. Now remember, when you do observational studies, that if you don't have enough variability of either the exposure or the outcome, you won't see an association. Okay, so if you have study A, salt intake and systolic blood pressure, everybody has the same level of salt intake, high or low, you won't see an association, right? Well, you see a weak association. But if there is a study in which there is lots of variability, then you see an association. Are they right or wrong? No, there is no right or wrong. It's different settings. I mean, that's observational epidemiology, right? So there's a strong correlation here. So they are heterogeneous. And one of the things that I always tell my students, you know, simplicity involves using certain things that will help you a lot, certain simple things that will help you a lot. Calculate the coefficient of variability for different variables and see if that variable has enough variability to allow you to study it in an observational mode, okay? And of course, the coefficient of variability is important because it sort of standardizes different variables. They may have different ranges of values. Okay, in AP introductory courses, beware of ecological correlations, right? So we all know that correlation doesn't imply causation. Now you can laugh, it's funny. And actually, you look at this, there's a perfect correlation, almost perfect, between per capita consumption of mozzarella cheese and civil engineering doctorates awarded in the United States. Perfect, okay? So this is what we call ecological fallacy, right? And this one you won't guess. This one is the funniest of them all. This is the relationship between number of storks and the size of the population. So maybe what we tell the children has some element of truth, right? If you believe the data, if you don't know epidemiology, I mean, it's ecological fallacy, of course. So it is not all ecological correlation, ecological fallacy. So if you do an observational study, you don't have enough variability, the ecological correlation may help you. For example, in each population, everybody has a very, very similar consumption of salt, A, B, C, D. But the averages are going to show a dose response. And that's more or less what happened with salt intake and hypertension, okay? And in fact, this is the Intersalt study showing a linear relationship in which each dot represents a different cohort. All right, it's not perfect, but there's a strong suggestion of a linear relationship when you look at population averages or cohort averages. Okay, so homogeneity is not necessarily evidence in favor of causality or effectiveness because of publication bias. And heterogeneity is not necessarily evidence against causality or effectiveness. So I think it's terribly important to know the determinants of homogeneity and heterogeneity before you use this concept in support or against effectiveness or causality. So this is important. Okay? So let me finish with decision analysis. Then we'll have a lot of time for questions. And I have a hearing loss, although my wife says that I only hear what I want to hear. That she's not true, right? I do have a hearing loss. So if you ask a question, speak up, okay? So the last issue that I'd like to discuss is decision analysis. What I'm going to show you is a very simplified model, okay? It doesn't really reflect the complexity of the issue, but just to give you an idea of an issue that is terribly important to public health, which is the difference between efficacy and effectiveness. So let's go back and talk about decision analysis, which is an evaluation of programmatic options. And this is a decision tree. How many people are familiar with decision trees? Okay, so a few people are familiar with decision tree. So decision trees have a decision node, which is under the control of the investigator. And they have chance nodes that are out of the control. They are not in the control of the investigator. And in this example, The decision node is program A or program B. I have to decide which one I want to implement. And the chance nodes are compliance, yes or no, with the program, and social class, high and low. So this is a simplification, of course. And then you have the distributions. For example, program A, 70% of people comply. Do you see that? I don't know, is this a, I don't think this, is this a laser point? Oh yeah, this is a laser point. So you see that for program A, 70% comply, 10% in a high social class, 90%, and in each one of those paths has a certain mortality. So what you have to do is just, you have the joint probability of that by multiplying each one of those paths. For example, you can see here that for those people who comply with the intervention, program B has a lower mortality than A. Let me show you. So this is just people who comply in both programs. And you can see that program B has a lower mortality, half the mortality of A, right?